What's up, Ninja Nerds? In this video today, we're going to be talking about Cushing syndrome and Cushing's disease. This is a part of our clinical medicine section. If you guys like these videos, they help you, they make sense, please support us. Some simple ways that you can do that goes a long way with the YouTube algorithm is just hitting the like button, comment down in the comment section, and please subscribe. If you have the ability to, I really highly suggest that you guys go to our website. You can do that by clicking down in the description box below. There's a link that'll go to our website. We have a lot of awesome tools, such as things like notes, illustrations. We have tons of quiz questions, and we're even developing exam prep courses. So please go check that out. I think that you'll truly benefit from it. Without further ado, let's talk about Cushing. So there's two different types, and then there's like this little extra one that we kind of chuck in there a little bit. There's Cushing syndrome and there's Cushing's disease, and we'll talk a little bit about this one last. Cushing syndrome is another way of kind of calling it like a primary hypercortisolism. So remember how we talked about this a lot, like primary and secondary hyper and hypothyroidism, and same thing with adrenal insufficiency. You can kind of think about this the same way, but pertaining to this in the sense of it's a primary hypercortisolism and a secondary hypercortisolism. So that's the way we're going to look at it, and it makes it easier to think about it that way. So Cushing syndrome is a problem with the adrenal gland itself, particularly the adrenal cortex. So you have to remember there's different layers. There's the zona glomerulosa, zona fasciculata, and the zona reticularis. What happens is for some reason, there's something hyperfunctioning of the adrenal gland usually that ends up pumping out tons of cortisol into the bloodstream. So for whatever reason, there is an increase in cortisol release, particularly from the zona fasciculata. And so this thing is just pumping out cortisol. Whenever cortisol is released in high amounts, what it does is it tells the hypothalamus that the cortisol levels are high. Hypothalamus has to say, okay, I got to shut down the cortisol pathway for a little bit. So what I'm going to do is I'm going to release a molecule called CRH. But I'm going to release it in a very slow amount, or pretty much not at all. All right, the reason why is if there's less, whoa, you saw that, that's pretty cool, right? If there's less CRH, that'll tell the anterior pituitary, hey, less CRH, I need you to make less ACTH. So that's what will happen is there'll be a less production of ACTH. Now, ACTH is important because whenever the levels of this are low, it's going to have less, what? Feedback. Because what happens is low ACTH means that you're going to try to tell the, in this case, the adrenal cortex, hey, stop producing as much cortisol. But in this disease cycle, there's no ability of the ACTH to kind of say, hey, stop making cortisol. Because in this particular scenario, the adrenal cortex just keeps pumping out this cortisol. The question is what's causing this increase in cortisol production? It's usually two particular things. One is it's from the adrenal cortex itself, right? There's some type of hyperfunctioning of this puppy, right? And we'll talk about what that reason is. It's not hard to remember, but there's a hyperfunctioning of the adrenal cortex. The other thing is that there's no adrenal cortex problem at all. What actually maybe it is that there's some type of exogenous steroid use. So somebody is actually taking exogenous steroids, and this is a lot of the time, we'll talk about this a little bit more in detail when we get to that point. This is happening in usually patients who have underlying like autoimmune diseases of some sort. But what happens is that steroid that you're giving ends up acting just like cortisol, resembles cortisol. Even though it's not being produced from the adrenal cortex, you're taking it via pill or injection, it's getting into the bloodstream and acting like cortisol. So these are the two particular components here that I want you guys to think about with respect to Cushing syndrome. It's a primary hypercortisolism with a reduction in ACTH. Now let's talk about these two particular pathophysiologies. There's a hyperfunctioning adrenal gland. So this thing, whatever it may be, is pumping out tons and tons of cortisol. And that's really the trigger for all of this process. But you have to start asking yourself the question, what is this thing? What is this goombach that's hanging off the adrenal cortex? It's an adrenal adenoma. So adrenal adenomas are by far going to be the most common cause of a hyperfunctioning adrenal gland, leading to its massive production of cortisol. In very small populations, you may have adrenal carcinomas that can cause this, but it's very rare. It's oftentimes adrenal adenomas that are the trigger for this. That's really all I want you guys to think about that. There's no like really high yield epidemiological or high yield pearls for your USMLE step 1 or to step 2 or even your PANCE that really helps us any more than that, other than knowing it's an adrenal adenoma. It's the most common cause of a hyperfunctioning adrenal gland. That leads us to the next component here, which is an exogenous steroid use. So we talked about this before. Exogenous steroid use means that the patient's likely on some type of corticosteroids. And when they're on these corticosteroids, it's usually chronic use. Right? So they're using chronically corticosteroids for a long time. What are the different types of corticosteroids? Well, there's many of them, right? Oftentimes, we can think about a couple here. Prednisone, I'd say, would be the most common culprit because this is one that you usually take on an outpatient basis because it's usually oral. You could also consider things like prednisolone. I would say it's less commonly utilized though. Another one would be methylprednisolone, but this is usually going to be in a patient who is more in the hospital because this is more of an IV medication. So with that being said, it's usually patients who are on chronic corticosteroids. The reason why is these chronic corticosteroids, I already told you, end up acting or resembling an increase in cortisol. So these resemble an increase in cortisol. Now, you have to start asking yourself the question, what would be a reason that people would be on chronic steroids, chronic corticosteroids? Well, there could be a couple different reasons. One is that maybe the patient has an underlying autoimmune disease and they need to take this to suppress their immune system from attacking itself. Or maybe they've had a transplant of some sort and they need some type of steroid use to suppress their body from rejecting that transplant. Either way, you have to think about, is the patient taking immunosuppressant medications such as corticosteroids, or are they taking it for an autoimmune disease? That would be something that I'd be thinking about here. That's why it's really easy to elucidate this from the history as compared to this, you may need imaging. All right, with that being said, we've talked about Cushing syndrome. And it takes us to the next aspect here, which is now we have to talk about Cushing's disease. So with Cushing's disease and ectopic ACTH production, we have to now start kind of narrowing our mindset here, which is talking about, okay, it's no longer an adrenal gland problem, my friends. It's probably something to do with the pituitary or some type of ectopic source. So let's talk a little bit about that. So with that being said, in Cushing's disease, I want you to think about it more as like a secondary hypercortisolism, meaning the pituitary is the problem here. And what the pituitary is doing is it's pumping out a lot of ACTH. When you pump out a lot of ACTH, you have ACTH receptors that are present on the adrenal cortex. It'll tell the adrenal cortex, hey, lots of ACTH, buddy. Go ahead and start pumping out cortisol. And as a result, that's what will happen. We'll end up with an increase in cortisol within the bloodstream. So either way, the primary endpoint here is that cortisol is high. It's just how the cortisol is elevated determines if it's Cushing's syndrome or Cushing's disease. In Cushing's syndrome, it's the adrenal cortex. In Cushing's disease, it's a pituitary problem, increased ACTH production. Now, that's one component. It's a pituitary problem, right? And usually the most common cause of this is hyperpituitarism. And we'll talk about what triggers this, but it's either way, it's pretty straightforward. The pituitary is pumping out ACTH. The other one is you could have an ectopic site. So some tissue cells are gaining the capacity to produce hormones. That's interesting. And so usually whenever you have an ectopic site that's producing hormones such as an increase in ACTH, same thing here, here's some tumor cells, they're producing ACTH, they're then triggering the adrenal cortex to make cortisol. This is going to be an ectopic site. ACTH should not be being produced by any other cells except for the pituitary. If it is, it's an ectopic site, and we call this likely a Paraneoplastic Syndrome. That means that there's likely a tumor somewhere in the body that is pumping out ACTH and triggering an increase in cortisol. So you have to think Cushing syndrome, increased cortisol, decreased ACTH. Cushing's disease and ectopic ACTH production is high ACTH and high cortisol. Now, with that being said, let's move into the next component here, which is, okay, it's either hyperpituitarism or paraneoplastic syndrome. What causes hyperpituitarism? In other words, what's causing this pituitary gland to pump out very high levels of ACTH? And it's actually relatively straightforward. If you guys remember from the pituitary disorders, there is a tumor that is usually present right here in the anterior pituitary, and it can start gaining the capacity to secrete ACTH. This is usually what we refer to as a pituitary microadenoma. So pituitary microadenoma, because you have to remember that macroadenomas, these have compressive effects. And whenever you compress the tissue, you lose the capacity of that tissue to produce hormones. This is a microadenoma. It's not going to have that mass effect. So whenever I say microadenoma, it has to be less than 10 millimeters in size. And here's the other thing. With pituitary microadenomas, they don't really have compressive effects. So they don't have the bitemporal hemianopia. They don't have headaches. But the thing is that they also have other hormones that are usually elevated. And so you want to think about, do they have an elevated prolactin, which is oftentimes the most common one? Do they have an elevated growth hormone? That could also be possible. And usually what would be a kind of a giveaway from this is if they have increased ACTH, and on top of that, they also have an increase in prolactin, an increase in growth hormone, and there is another one. It's called TSH. If the patient also had concomitant disorders such as galactorrhea, gynecomastia, acromegaly, and hyperthyroidism in combination with their Cushing's, you should really start thinking about a pituitary microadenoma that's producing multiple hormones. With that being said, the last thing that I want you to think about is a paraneoplastic syndrome. That's that ectopic ACTH production. There's a tumor somewhere in the body, and that tumor is pumping out ACTH, and that ACTH is the driver for cortisol production. You have to ask yourself the question, where's the tumor? Well, it could be anywhere, but by far, the most common cause is going to be small cell lung cancer, because this cancer will gain the capacity to produce hormones. So with that being said, we now know what's the trigger for high ACTH and high cortisol, pituitary microadenoma, or small cell lung cancer. What's the trigger for high cortisol and resulting decrease in ACTH? It's either an adrenal adenoma or chronic steroid use. Now let's talk about what are the long-term complications and some of the classic findings in Cushing's disease and syndrome. All right, my friends, so now we move on to the next component of this, which is talking about what are the classic findings of a patient who has Cushing's syndrome or Cushing's disease, and then what are the complications. We really did a pretty good job, I think, of kind of underlying and really explaining the pathophysiology and the causes of Cushing's syndrome, Cushing's disease, and ectopic ACTH production. So now what I want us to understand is, okay, how will these patients present? Well, first off, there's usually a very uniform presentation that's common among all of them, Cushing's syndrome disease and ectopic ACTH production, and that is that they usually all present with this interesting like fat redistribution type of presentation, which is they can present with a buffalo hump usually on their back, which looks like this. They also may present with a moon face, which is the swelling of their face, which looks like this. And then lastly, they may also present with a lot of truncal or abdominal obesity, which usually, sometimes we'll talk about in a little bit of a second here, has a lot of striae or stretch marks due to the skin atrophy process, which looks like this. What I want you guys to understand here is, why does the buffalo hump, why does the moon face, why does the truncal obesity actually occur? When we look at the adipose tissue here, what happens is cortisol plays a very prominent role in metabolism, and particularly lipolysis. And that's because during a stress response, whenever cortisol is released, it helps to trigger lipolysis, which that you can utilize those fatty acids and glycerol for ATP production in the muscles. But if cortisol is really elevated, what it'll do is it'll trigger the lipolysis process. And what you'll do is something really interesting. You'll undergo lipolysis, but it's more of the appendages. So in other words, you'll start breaking down some of the fat tissue present in the arms and the legs. And then what's weird is you'll also do something called redistribution of that fat. Now, this is what's interesting. I don't understand why this happens, but you move some of the fat towards the central portion of the body. So we refer to this as the kind of the more axial component of our skeleton. So it moves it to the axial skeleton. And then parts of that axial skeleton includes the back, the abdomen, and the face. And so that's why you get this buffalo hump, the moon face, and the truncal obesity, is because of an increase in lipolysis and an increase in fat redistribution due to the high cortisol levels. That's the very, very common presentation. You have to remember that. If you see that, you should have a high degree of suspicion for Cushing's. The next thing is that skin atrophy and striae that we talked about. This is actually due to proteolysis. So whenever cortisol levels are high, again, your body will tap into any kind of energy source that it really can, because it's using it for a stress response. So whenever cortisol is high, what it will do is it'll trigger what's called a proteolysis pathway. And what I mean is that you'll trigger an increase in the breakdown of proteins. And there's variable amounts of proteins and so many different types of proteins that we'll use to make amino acids and generate that for ATP in the muscles. One of the big ones happens to be collagen. This is a very prominent protein that's present in the skin. And if I start breaking down a lot of that protein or that collagen inside of the skin gets a little bit more weak and it becomes easier to stretch. And that's where we get this abdominal striae and skin atrophy. So it's really important to remember that. Here's the next thing that I really want you guys to think about. We will only see this presentation. So these, Cushing syndrome, Cushing's disease, you'll see it. This, you will only see in Cushing's disease. What happens is, in Cushing's disease, what we know is that there is likely a pituitary microadenoma that is pumping out what? ACTH, that's triggering the increase in cortisol. Same thing, triggering an increase in ACTH, right? That tries to increase the cortisol production. But you know what else is really interesting? There's a molecule called pro-opiomelanocortin. It's a precursor molecule that when it gets broken down, it makes ACTH. But it also makes alpha melanocyte stimulating hormone. When alpha melanocyte stimulating hormone is present, it'll then go and act on your melanocytes and stimulate these melanocytes to increase the production of melanin. When there is a lot of melanin that's actually produced, this will particularly deposit in the skin, or maybe the lips, maybe around the face, hands, feet, and it looks like this. So we see now that hyperpigmentation is a result only of Cushing's disease, not of Cushing syndrome. That is super important. The other concept here is that Cushing's disease, whenever you produce tons of ACTH, yes, you will have an increase in cortisol. But there's another hormone that is actually dependent on ACTH to a small degree, and it is called DHEA. Dihydroepiandrosterone, and androstenedione. Either way, these are androgens. Now, androgens in the female play a role of kind of acting like testosterone. When these are produced in high levels, these patients will exhibit more masculinization type of features. In other words, they'll get pretty hairy. They start growing like a full beard. It's called hirsutism, okay? The other one is they can also get a very interesting type of libido that kind of goes crazy. So this is the two particular features that you may see is hirsutism and increased libido and acne. Hirsutism looks a little bit like this. All right, so now we have an understanding here that in Cushing's disease only, you will have this pathway with hyperpigmentation and this pathway with masculinization. You will not see this in Cushing syndrome. The big thing that you have to remember is that there are many complications that can present with chronic Cushing syndrome or Cushing's disease because of that high cortisol in the body. We shouldn't be having cortisol levels elevated all the time. When they are, you get a bunch of complications such as one, which is secondary hypertension. We talked about this in the hypertension lecture, is that cortisol, when released in high levels, acts on these receptors called the alpha-1 receptors. And what it does is it stimulates these alpha-1 receptors by increasing the sympathetic nervous system activity of those receptors. So by having lots of cortisol, what you'll do is you'll increase the alpha-1 receptor sensitivity. So that when epinephrine and norepinephrine and all of those guys get around this vicinity, it'll really increase the vasoconstrictive mechanisms. And then what happens is your systemic vascular resistance goes up and your blood pressure will increase. And so oftentimes the reason for this elevation in blood pressure is because high levels of cortisol really squeeze the blood vessels pretty intensely. It may also to some degree increase your cardiac output, but it's not as profound. You know what else it can do? We talked about this a little bit in the adrenal insufficiency lecture. More the opposite effect is that cortisol to some degree does have a mineralocorticoid effect. It's minimal, but it is present. And so it may also help to increase sodium and water retention to some degree. And so if I increase my sodium and water retention, all right, then what I'm going to do is I'm going to have more like fluid and volume inside of my bloodstream. And so what happens is the blood volume goes up. And if my blood volume goes up, then subsequently, so will my blood pressure. So whenever these patients come in, this is the mechanism of them having high blood pressure, but how will it present? Usually secondary hypertension is classic in a patient who presents with hypertension despite 3+ anti-hypertensive agents. This is the real big thing that I need you guys to remember. If a patient comes in and they have high blood pressure and they're younger or they're on 3+ antihypertensive medications with no underlying trigger, you really want to think about, could they have secondary hypertension due to Cushing's syndrome or Cushing's disease? The next concept here is diabetes mellitus. Now, it's important to remember that yes, Cushing's syndrome and Cushing's disease can increase the risk of diabetes, but it's also more common that they will worsen a patient with underlying diabetes. What do I mean? Well, cortisol, you have to remember that it works on the liver, and what it helps to do is it helps to be able to increase your blood glucose levels. Without going crazy, I want you guys to remember that cortisol works on the liver and it increases your blood glucose levels via two particular pathways. One is called gluconeogenesis, and the other one is called glycogenolysis. Either way, these pathways are being stimulated and pushing more glucose into the bloodstream, causing hyperglycemia. Hyperglycemia, as a result, can lead to multiple complications long term, but what it also can do is it can stimulate the pancreas to make more insulin. And as you produce more insulin, your body starts to develop resistance to that insulin. And that's why these patients can have insulin resistance. So one of the very common manifestations of this is a patient who has very significant hyperglycemia. Oftentimes, maybe without a diagnosis of diabetes. You really want to think about that. Okay, my friends. The next component here is osteoporosis. With patients who are on chronic steroids for a long time, we actually do suggest that they get like DEXA scans because they're at high risk of osteopenia, osteoporosis, and as a result, pathological fractures. And so oftentimes what happens is, it's the same concept as actually right up here, is that cortisol leads to proteolysis. And so whenever I get a lot of proteolysis, guess what one of the most common proteins are inside of the bone? It gives a lot of the strength and integrity to the bone, collagen. And so because I get a lot of collagen that gets broken down, unfortunately, the bones become weaker. And the patients usually progress through a couple stages where the bones become really, really thin and weak, called osteopenia. Maybe they start becoming really weak and very, very porous, called osteoporosis. And then lastly, they may present with, and this is usually the most scary kind of complication, is they may present with pathological fractures, especially of more of the weight-bearing bones like the femur. And so with elevated cortisol levels, you get increased proteolysis, and you accelerate the bone destructive pathway that can lead to osteopenia, osteoporosis, and pathological fractures. So in patients who are on chronic steroids, you really want to be considering working them up for considering these things. So how do I do that? Usually, we often do DEXA scans to look at the bone mineral density to see if it gets less than -2.5. That suggests that they're going towards an osteoporosis pathway. And then the other concept is looking, do they have any pathological fractures, and seeing if they have an underlying elevated cortisol level. So these are some big things that I really want you guys to think about here. Is underlying pathological fractures or a reduced bone mineral density due to elevated cortisol levels in the setting of Cushing's. Last thing, well, almost last thing. Cortisol is interesting. It's a stress response hormone. So when it's released, what it does is it tries to kind of help to amp up a lot of our systems, right? Increase our sugar, increase our blood pressure, and do a lot of these things to help to initiate the stress response. However, one of the unfortunate things that can happen is that cortisol can actually cause an immunosuppressive effect. What do I mean by that? So in other words, we have different types of cells called neutrophils. We can inhibit these neutrophils, and we do it via an interesting way. Neutrophils are supposed to move from the bloodstream and squeeze through the blood vessels and go out and fight off this bacteria. that's called diapedesis, it'll actually inhibit that process. And so lots of neutrophils actually stay up in the bloodstream. And sometimes it actually can create a false, interesting lab value called a very prominent leukocytosis, and that's usually due to steroids. The other thing is it can also suppress lymphocytes, T cells and B cells. And so now you inhibit these lymphocytes, which produce antibodies and help to play a role within our immune system function. Now you lose the ability of these immune system cells to come out here and fight off these pathogens. As a result, these pathogens can stay inside of the interstitial fluid or wherever the tissue space is and colonize and build up. And as a result, this can lead to infections. And there's so many different types of infections, and that's what you have to watch out for. Oftentimes, it's usually fungal infections that is the most common because it's kind of like an opportunistic infection if you want to think about it. You're immunosuppressed, you allow for fungi to grow. So fungal infections tend to be the most common. I'd say one of the biggest ones is going to be candidiasis. So candidiasis would be a really big one that you don't want to think about. Think about the oral thrush. Sometimes it can even get down into the esophagus as well. The other one is like skin infections, so watch out for cellulitis, and I think one of the big ones that it really is an opportunistic bacteria is MRSA. So you really want to watch out for MRSA, which is a methicillin-resistant Staphylococcus aureus. The last one is another opportunistic infection, but particularly to the lungs, and this is called pneumonia. Now, pneumonia is usually something that we see in infections that are, again, opportunistic, which is called pneumocystic jirovecii pneumonia. And this is someone who is usually having HIV with a CD4 count that's relatively low, like less than 200, or they're significantly immunosuppressed. So watch out for infections, but I'd say the most common one is going to be usually your fungal infections. The other thing that's actually really helpful to remember is that sometimes cortisol, whenever it's really, really elevated, it will inhibit this diapedesis pathway where neutrophils are supposed to come out here. So neutrophils stay in the bloodstream. And so watch out because sometimes these patients can have very, very high white blood cell counts. And it'll make you think that they have like some type of infection. They have a leukocytosis. But oftentimes it's because you're inhibiting neutrophils from undergoing that diapedesis and that margination pathway, and so instead they stay in the bloodstream. So watch out for a increase in the white blood cell count with a prominent neutrophil amount, but it's not due to an underlying infection. It's just due to this inhibition of margination. Lastly, when cortisol levels are elevated, again, it plays a role within our stress response. So when cortisol levels are low, we're kind of lethargic, you're more fatigued, everything's kind of shut down in the brain. But whenever the cortisol levels are high, you're amped up, your stress response, your sympathetic nervous system is on edge. And so oftentimes these patients develop severe agitation, and sometimes, I'm not even kidding, these patients can develop psychosis. I've seen it in the ICU a lot, where patients can develop like agitated delirium, and it progresses to full-on psychosis. This is usually whenever you're giving them large amounts of steroids for whatever reason, but you want to watch out for this because over time, patients can develop agitation, they can develop insomnia, and they can even develop psychosis. So these are really, really prominent things that I have to have you guys remember, respectively with Cushing syndrome and Cushing's disease. So with all of this being said, we see a lot of things going on here with Cushing syndrome and Cushing's disease. The biggest ones that you have to remember for classic findings is the skin atrophy striae and the fat redistribution signs. That is the most important thing to think about. Oh, this patient could have Cushing's. Then think about, do they have other complications going along with it? Most commonly, secondary hypertension is a big one, osteoporosis, and very high risk of fungal infections may cue you to start thinking about, does this patient have Cushing's? And now let's move into the diagnostic workup. So the first question is the cortisol high? That's all I gotta know. Problem is we gotta do at least 2 to 3 tests to see if it's positive. So one is the 24-hour urinary cortisol. If that cortisol is elevated throughout the entire 24-hour period, that suggests a hypercortisol state. The other one is I want to do something called a low-dose dexamethasone test, maybe like 1 milligram of dexamethasone. It's basically a steroid. It's a little bit of cortisol. What it'll do is, in normal individuals, normal patients who don't have Cushing syndrome or disease, it'll suppress the anterpituitary, tell it to stop making ACTH, tell the adrenal cortex to stop making cortisol. And their cortisol levels should be low. But if their cortisol levels are high, that tells me that there's a Cushing's disease or syndrome present. It means that the anterpituitary is not responding to the low dose of dexamethasone and it's still producing ACTH, or it tells me that it doesn't really matter because the adrenal cortex is still producing cortisol regardless of what you give them. So if they have high cortisol, despite getting a little bit of steroid, it tells me that they're not normal and they likely have Cushing's. If I also test a late night salivary cortisol and that ends up being elevated, again, tells me the cortisol levels are high. So if 2 out of these 3 tests are positive, now I can go ahead and move on and say this patient probably has some degree of Cushing's. I just got to figure out which one. Is it coming from the pituitary, an ectopic tumor, or is it coming from the adrenal gland? If I get an ACTH test, that should tell me. If the ACTH is high, it's then coming again from some type of pituitary tumor or a lung tumor. So it's probably Cushing's disease. The next thing I got to figure out is it the tumor from the pituitary or is it a tumor from the lung? Now, you can do 2 tests or you can do one of the 2 tests. You can do a CRH stimulation test or you can do a high-dose dexamethasone test. The concept behind this is that the pituitary, if you have pituitary microadenoma and you give it CRH, it will stimulate that anterior pituitary to make more ACTH. It won't really do that for the ectopic site. If you give them high-dose dexamethasone, that'll actually suppress. If you give them like 8 to 10 milligrams of dexamethasone, it is strong enough to suppress the anterior pituitary tumor and tell it to stop making as much ACTH and therefore cortisol. So if I do this and I suspect that it's pituitary, I will have an increased response to CRH and I will have a decreased response to dexamethasone. This right here tells me that it's coming from the pituitary. But if I think that it's ectopic, I'll give them CRH and it won't make any difference. It won't really change their ACTH. It'll still remain elevated. If I give them high-dose dexamethasone, it won't really matter. The ACTH and their cortisol will remain the same because it's not going to be suppressed or it's not going to be stimulated. Now, before we show you that here, again, if I think it's pituitary source, what's the best thing to do? Once I have this kind of degree of confirmation, I can get a pituitary MRI. Oh, there's she below. There's our pituitary microadenoma. That's the cause of this. But again, if I do this test and I say no change, it's likely that's some type of ectopic site. So what's the most common area? The lungs. So I can probably do a pan-CT scan or a PET scan. Usually just make sure the most common one is lung cancer, but make sure it's not a tumor somewhere else in the body that's the cause of this. All right. Now, the other scenario is what if the ACTH is low? That's definitely primary. So that tells me the cortisol is high. It's suppressing the anterior pituitary. It's telling it to shut down the ACTH. So it's Cushing's syndrome. So then I got to remember the most common causes here is usually adrenal adenoma or chronic corticosteroid use. So what should I do? Get a CT. If I get a CT of the abdomen, adrenal CT, adrenal MRI, and I see that they got a big old adrenal adenoma, I'm done. I got the diagnosis. And if it's not there and I look in their history and it suggests, oh, it's probably the chronic steroids that they've been on forever, then I know the cause. And this is how we would go about diagnosing this. Now, for treating Cushing's syndrome and disease, it's important to, again, remember which one it is. So if a patient has Cushing's syndrome, it's usually due to steroids that they're taking chronically, or it's due to them having an adrenal adenoma. So you have to ask yourself the question, is it steroid related? If it is, start tapering down the steroids. So reduce their dose so that they're not having that high jump of cortisol and then suppression of ACTH production. All right, so start tapering them down. If it's not steroid related, then it's probably adenoma related. So in that particular situation, you have to reduce the endogenous production of the steroid. I have to suppress the adrenal adenoma. And how do I do that? Oftentimes you give them a drug called ketoconazole. So you're like, wait a second, I'm going to give them an antifungal? Yes, but ketoconazole has been shown to be able to suppress steroid hormone synthesis, especially cortisol. So if I give them ketoconazole, I'm only really doing it because I'm trying to suppress the cortisol production, and it's usually going to temporize them long enough to be able to get them to a surgical procedure like cutting out that tumor. If they're not a surgical candidate, though, I'm just going to unfortunately have to continue the ketoconazole and monitor their LFTs pretty consistently. If they are a surgical candidate, cool. I've tampered down the cortisol pretty well. I've suppressed it. Now we can go ahead and we can cut out that adrenal tumor by doing an adrenalectomy. Cushing's disease is a little bit different, right? So it's a pituitary problem or it's a squamous cell, a small cell carcinoma problem with the lung. You have to, again, for these patients, regardless, reduce their endogenous production of cortisol. So they're going to continue to keep pumping out ACTH. That's going to tell the adrenal cortex to continue to make cortisol, at least suppress the pathological effects of the high cortisol by giving them ketoconazole. And again, for these patients, you're not going to be doing an adrenalectomy because their adrenalectomy is not the particular issue. It's not the adrenal gland that's the problem. It's the pituitary gland that could be the problem. So what would you do to remove a pituitary tumor if they have one? You do a transsphenoidal resection of the pituitary microadenoma, and then you lose the source of high ACTH. The other scenario, if a patient has small cell lung cancer, that's a little bit more intense. We'll talk about that in the actual lung cancer section, but that may involve more chemotherapy and radiation. You might have to continue those patients on ketoconazole for a long time. All right, my friends, that covers Cushing syndrome and Cushing's disease. I hope it made sense. I hope that you guys did enjoy it, and as always, until next time.